A tall, thin 25-year-old woman presents to the surgical clinic with a complaint of a swelling in the front of her neck for the last 4 months. On clinical examination, she has a swelling in the left lobe of the thyroid with multiple neurological lesions within the oral cavity or neuromatous lesions. Blood pressure is high. Investigations, calcium and electrolytes normal. Serum calcium VMA levels are elevated. What do you think?
It's likely cause of hypertension, fake chromocytoma. This is
So,
men type 2.
hypertension and elevated urinary vinyl mandelic acid. This is pheochromocytoma secreting noradrenalines and adrenalines. Yeah. Next one.
65 years old man present with hematuria, left loin vein. Computed tomography demonstrate left renal tumor, undergo left radical nephrectomy. Where does left renal artery lie? This is posterior to left renal vein. The most anterior is the vein, then the artery, then the ureter.
Very nice. So if this is the kidney, then you have valve, vein, artery, and then ureter or pelvis. So valve, vein anterior, artery in the middle, and then uh, pelvis of the kidney or ureter is posterior. Next one.
Within the posterior triangle, which nerve at the posterior at the particular risk of damage? Spinal accessory nerve.
So spinal accessory is subject to be injured, but please know that you have here, if you will see the neck like this, and this is the midline, and this is the mastoid process here, and this is the sternocleidomastoid, and this is the trapezius. So this is the trapezius muscle, and this is the sternocleidomastoid muscle. So if the nerve will come like this, so if you will look at the posterior triangle here, the injured nerve in the posterior triangle will deprive sternocleidomastoid, but the trapezius is already been supplied. So when I asked you about spinal accessory injury in the posterior triangle, you will spare shoulder movement because the trapezius will be already be supplied, but the sternocleidomastoid responsible for contralateral neck lateral rotation will be affected. Next one.
Yes, right and left pulmonary arteries derived from which of the following embryological aortic arch? 6.
So we can post the embryology lecture for you to remember every pharyngeal arch. Next one.
47 years old man present to emergency 6 hours after climbing an accident. Initial assessment suggests he had lost 1 liter of blood. Blood pressure 105 over 70. Pulse is 88. Catheterized and his bladder contained 120 ml of urine. Activation of which of the following transport system best describe aldosterone lead to maintenance of intravascular volume and oliguria in this man. Sodium potassium in the collecting duct.
So ENaC or NENAC channels acted by aldosterone. Aldosterone acts on present mainly on late distal convoluted tubules and collecting ducts, but mainly in collecting ducts. So the answer would be E. Next.
During arch orthography, vertebral artery would be seen to arise directly from subclavian artery.
Subclavian artery. There is very difficult question regarding Lima we will post on the group. Lima, left internal mammary artery graft. When you have, we will post it on the group, no problem. When you have Lima, this is very important anatomy question, left internal mammary artery graft to the coronary. So this is the heart, and this is the subclavian, left subclavian artery. So when I ask you about this Lima graft and another angina happened, so there is a Steele syndrome because of obstruction in the subclavian artery proximal to all of these branches, proximal to to anterior scalene insertion, proximal to Lima origin, and this will lead to diversion of the blood to the upper limb while you are doing anything from the graft in subclavian artery obstruction in this region. Okay. You can ask, I will put it on the Telegram group. Next one.
A 65-year-old man remain on the high dependency unit following gastrectomy 3 days previously. His urine output has averaged 80 ml per hour for the last 24 hours. He has one dry abdominal drain and no nasogastric losses. His urea and electrolyte are normal. He is to stay in by mouth for further 24 hours. Which of the following fluid regimen is most appropriate to his electrolyte and water requirements over the next 24 hours? 1 liter of normal saline plus 1.5 liter of 5% dextrose.
Nice guidelines. You must put a range of 1 to 2 millimole per kg per day of sodium and 1 millimole per kg potassium. This is the daily requirements for sodium, is 1 to 2 millimole per kg per day. So if you consider this man 80 kilogram, for example, so you can multiply this, so you will need 80 to 160 millimole per day sodium. Normal saline bag will provide about 145 millimole per liter. So we need only 1 liter saline to provide all needed daily required or all required daily sodium, which is already been done by 1 liter of normal saline, 0.9%. And also we need 5 to 100 gram glucose as per NICE guidelines. So 1 to 2 liter glucose will give the reasonable amount of daily required glucose. So B would be the most reasonable answer. Next one.
A 3-year-old boy admitted to hospital with severe vomiting. Radiographic examination reveals that he is suffering from annular pancreas. Which of this structure is constricted? Second part of duodenum.
Very nice. Why? Because as you know, the origin of the pancreas, we have ventral bud and dorsal bud. From where would be the ventral bud?
From the mesothelium of the duodenum.
No, I'm talking about the origin of the pancreas.
Yes, ventral will be the accessory duct and uncinate process.
This is from where?
From the ventral bud.
From hepatic?
From the ventral bud.
From the hepatic. So again, there is a ventral part and dorsal part. We have the annular pancreas because of a growth of a pivot ventral pancreatic bud, which will fuse with the dorsal bud, forming a ring around the duodenum. Do you know from where the dorsal and ventral one? Ventral pancreas and dorsal pancreas?
What I know is they are buds from the mesodermal cells of duodenum.
No.
I don't know.
Ventral from the hepatic origin and dorsal from the duodenal origin. Hepatic diverticulum. Okay,
Okay.
next one. So you will have like this. If you draw it here, you will draw the duodenum like this, and you will have the annular pancreas like this. Around the ventral and dorsal origin will around the second, the D2, as a ring. Next one.
Yes. 20 years old man with severe head injury is being ventilated using intermittent positive pressure. Which of the following is a physiological consequence of this? Decreased cardiac preload.
Cardiac preload. Why?
Because
Because
positive pressure will lead to decreased venous return
this
and decreased end diastolic volume, which equal cardiac preload.
very nice. Next one.
A 36 years old man present with 2 months history of low back pain radiating to his left leg. After clinical examination, referred for MRI scan. This show a prolapsed intervertebral disc. The clinical signs are consistent with pressure on S1 root, which combination is most likely to be found. So, weak ankle plantar flexion, altered sensation on sole of foot, loss of ankle jerk reflex, so it will be D.
Very nice. Next one. Next one.
Yes. 55 years old woman undergo a cholecystectomy. The gallbladder contain multiple dark irregular small stones. The most likely cause of this type is unconjugated bilirubin.
Why?
Because the dark irregular small stones equal pigment stones, which results from increased destruction of red blood cells or hemolysis, and this lead to increased unconjugated bilirubin.
Very nice. Next one.
A 55 years old man present with a deep venous thrombosis. Full blood count show hemoglobin of 18.3, white cell count of 8, and platelet count of 200. The hematological picture is most likely to be associated with renal cell carcinoma.
Next one. Pancolitis last 5 years. Which of the following is least likely to develop with this colitis?
Polyarthritis.
Toxic megacolon, if this is polyarthritis, maybe iritis, maybe cholangitis, maybe arthritis. But polyarthritis nodosa, is that common with colitis?
No.
So the answer is D. Easy question. Next one.
Finished the incision for access pelvic organ. He incides abdominal wall down to and through the rectus chest. He retracts the rectus abdominis laterally from the midline to expose the fascia transversalis.
Fascia transversalis. Okay, so you have to check eye sense anatomy in abdomen. You will find that in or any atlas, you will find that below arcuate line there is deficient posterior rectus sheath. So you will find direct no posterior rectus sheath. You will find direct fascia transversalis directly. So after retraction of the rectus, you will or division, you will find the fascia transversalis then. Next.
25 years old man undergoes splenectomy following blunt abdominal trauma. 3 days post-operative venous blood testing is likely to reveal high platelet count.
Very nice. So in asplenia, you have to check a splenia folder on your group that you will have features of after splenectomy. First, you will find what's called Howell-Jolly bodies, lymphocytosis, neutrophilia, reactive thrombocytosis, usually at the first weeks, 2 months after splenectomy, and decreased production of immunoglobulins G and IgG and IgM, decreased complement activation and C3b opsonization. And please note that the lack of Howell-Jolly bodies can, in asplenic patients, can be suggestive of presence of an accessory pancreas. Sickle cell anemia can lead to autosplenectomy. Next one.
A 46 years old woman is seen in pre-admission clinic. Myocardial infarction 2 years ago. On examination, she is atrial fibrillation, and recent echocardiogram shows that he has dilated left ventricle. She is on warfarin, and her INR is 6.1. Warfarin inhibits which of the following? Prothrombin.
Prothrombin is factor 2, and warfarin acts on vitamin K aporeductase enzyme. So it is inhibitor for this enzyme, leads to vitamin K dependent clotting factors inhibition. 2, 7, 9, and 10. So 2 is the prothrombin. Next one.
A 75 years old man is admitted for elective repair of abdominal aortic aneurysm. Following his operation, his systolic blood pressure fall below 90, and during resuscitation, he is given an infusion of fluid. There is a choice of colloid or crystalloid, which the following describe why the intensive therapy unit registrar decide to administer a colloid, because colloid are not freely filterable across semi-permeable membrane.
So your answer is
A.
A. Okay. Next one.
35 years old man developed septicemia following surgery for perforated acute appendicitis. He is hypotensive. Arterial blood gas analysis revealed pH acidotic, BCA2 increased, bicarb decreased, mixed metabolic and respiratory acidosis.
Okay. So you will find that pH is low, PaCO2 is high, bicarb is low. This is both respiratory high PaCO2 and metabolic low bicarb can explain the acidosis. So this is mixed picture of acidosis, and PaO2 is low. This is already PaO2 less than 8. This is respiratory failure type 2. because PaCO2 is high. Next one.
A 20 years old man present to emergency with a stab injury to senar eminence. On examination, found to have a 2 centimeter long laceration with loss of sensation in the thumb and index finger, weakness of the senar muscles. Which of the following structure most likely to have been injured? Sensory and motor branches of median nerve.
Okay. Next one. A 65-year-old man presents with vomiting, weight loss, and 3 palpable epigastric masses. The transpyloric plane, this is very easy question, asking about L1. Transpyloric plane located at L1. Next one. A 30-year motor cyclist is brought to A&E after RTA, open fracture right femur, arrival tachypnic, confused, cold, clammy. So I know this question may be answered wrong because this will explain your knowledge regarding the stress response to injury or surgery. So you'll have activated renin-angiotensin-aldosterone system with catabolic state. So sensitive glycogen is wrong. Increased secretion of sodium is wrong because there is salt water retention and potassium loss. Increased pH, this is wrong because you will have dehydration state or hypovolemic state because you see here the patient's confused, cold, and clammy skin. So you will find the patient in metabolic acidosis state. So B is the answer. Next one.
In an emergency situation, what's the most appropriate surgical method for obtaining an airway? Cricothyroidotomy. Piercing the cricothyroid membrane.
Very nice. Cricothyroidotomy, surgical emergency for the access of the airway. Next one.
75 years old man present with hepatomegaly, ascites, CT show evidence of post-hepatic portal hypertension. Inferior vena cava pass through the diaphragm at which of the vertebral level? T8.
Very nice. Vena cava are 8 liters. T8 is the answer. Please know that right vagus will go with T8 in vena cava hiatus. Yeah. Next one.
Right phrenic.
Right phrenic. Yeah.
Yes. 20 years old, the woman present acutely with abdominal pain imaging show right ovarian cystic lesion which is excised. Histological examination cyst lined by keratinizing structure. 20 years old woman present with acutely with
right vagus is vagi with esophagus T10, but right phrenic, again right phrenic, as we discussed in the previous video, will go with T8 with vena cava hiatus. So vagus esophagus T10, but right phrenic with inferior vena cava, phrenic inferior vena cava. Next one.
20 years old woman present acutely with abdominal pain imaging reveal right ovarian cystic lesion excised. Histological examination cyst lined by keratinizing stratified squamous epithelium, areas of fat, muscle, thyroid, neural tissue. Was appropriate pathological designation of this teratoma.
Very nice. So we have a mnemonic here. Do you know it? Do you know about it? So seminoma is like seminoma commonest HCG 30s to 40s, the age and radiosensitive. But teratoma 20s to 30s, alpha-fetoprotein. So teratoma T 20s to 30s and alpha-fetoprotein. Okay, but seminoma commonest means that it's more common than teratoma, and HCG, so seminoma HCG, 30s to 40s and radiosensitive. Next one. So teratoma 20s. Yeah, next one.
A 25-year-old woman who is 2 months postpartum, present tender mass in left breast. She is pyrexial, raised white cell count, raised TRP, a diagnosis lactational mastitis.
Staph aureus, yeah. So you know it. Breast abscess, mastitis, yeah. Next one.
62 years old alcoholic, severe acute pancreatitis, 3 days after admission, become hypoxic, confused, just X-ray uniform calcification of both lung fields, adult respiratory distress syndrome.
ARDS. If I told you that PCWB is normal, then this will be ARDS. PCWB will be normal. If I told you this is a cardiogenic cause of pulmonary edema, you will find BCWB, the pulmonary capillary wedge pressure, is high, more than 18. Why?
Okay.
Because we told you before that here is the lung, okay? Here is the heart. If you have the venous return from the lung to the heart, to the left atrium, and then to the left ventricle. So if you have ARDS, the reason for ARDS most commonly sepsis, okay? So or blood transfusion or whatever. So the lung alveoli will be exudating fluid. So it will be edematous and there will be bilateral opacifications of the kidney. And you will have ARDS. Okay, so the pathology in ARDS is a pathology in the lung, secondary to any systemic thing. Okay, so you will
Yes.
find BCWB normal. Okay, but if you have cardiogenic, this is called already lung edema due to acute respiratory distress syndrome in the lung itself. But if you have cardiogenic pulmonary edema, means that the heart is the origin, like ventricular, left ventricular dysfunction, or ischemic heart disease, or valve disease. So you will find that the heart is in failure. So it could not receive any blood from the lung. This will go back, leads to congestion, pulmonary venous congestion in the lung, leads to exudation of the fluid, so leads to cardiogenic cause of pulmonary edema. So the pressure in the pulmonary capillaries will be high. So BCWP will be high in cardiogenic pulmonary edema. Okay. Next one.
Now, 58 years old woman present emergency with large fluctuant swelling at the site of recent insect bite, anxious, tachycardic, pyrexial, ECG show critical fibrillation, noted to have a goiter, swelling at the site of the bite requires surgical drainage. Which of the following class of drug would most be appropriate for pre-operative preparation? Beta blocker.
So please note that when you have crisis, thyrotoxic crisis, you will use beta blockers and thionamides. Don't select iodides, please. Again, the mainstay is beta blockers added to thionamides. Next one.
A nulliparous 30 years old woman present with recurrent painful red area in the areola. She gave history of smoking. The lesion excised histology shows squamous metaplasia and of lactiferous duct. Microbiology culture doesn't grow any organism. Which of the following most likely to be subareolar abscess?
Why?
Because the history of the age of the patient, history of smoking, no gross squamous metaplasia of the lactiferous duct is consistent with
What is
subareolar
the
abscess.
second name What is the second name?
Dactyctasia.
Or
Periductal mastitis.
very nice. So plasma cell mastitis is a benign breast condition in females around 30s to 40s with a subareolar firm mass. Okay, so the most frequently used classification for this, okay, like it is plasma cell mastitis, ductictasia, or it is just a different stages like periductal mastitis. This is just non-infectious, rare form of inflammatory, non-neoplastic mastitis, and subareolar imposition. By the way, the pathogenesis is not fully understood because it started with inflammation and the expansion of the milk ducts with the breast, and symptoms include pain and tenderness, nipple discharge, skin may be inflamed with the retraction of the nipple, and the acute signs of inflammation can disappear later on. Okay. Next one.
65 years old man undergo right hemicolectomy. On the second post-operative day, he is febrile, nauseous, he has a distended abdomen, but very little pain. He is on intravenous morphine by a patient-controlled analgesia pump. Plain X-ray confirms distended lower small intestine. The physiological basis of post-operative paralytic areas involve stimulation of B receptors.
Of what?
Of B receptors.
What are B receptors? It is actually like paralytic ileus. What is the most common electrolyte imbalance causing paralytic ileus?
Hypokalemia.
Yes. And paralytic ileus, what are P receptors?
Because one of the theories that involved in the cause of paralytic ileus post-operatively is the pain, which is induced by release of substance P, and this substance P lead to stimulation of P receptors, which lead to paralytic ileus.
Okay, I'm with you, but till now, it is like it is thought that mu opioid receptors play a central role in the regulation of bowel motility, and therefore can be more related to postoperative paralytic ileus.
But I think in this question,
So substance P receptor or mu receptors and centrally, and also kappa receptors peripherally, opioid kappa receptors can act on paralytic areas. And as we said, hypokalemia is one of the most electrolyte disturbance cause of post-op paralytic areas. Next one. Yeah, this
42 years old.
opsonization. So if you are talking about bacterial ingestion, this is phagocytosis. But if we are talking about the process of enhancement, this is phagocytosis of opsonization. So what are the factors for opsonization? C3, 5, and C3B. C5B and C3B. Okay, so do you know, can you tell me about opsonization factors?
Complements.
Yeah,
I don't know.
C3B, and what else? There is another one, as I remember.
I don't know.
C3B, C3B is the most common one, and C5 as well. C3b and C5. C3b induces phagocytosis of opsonized targets. This is called opsonization. Okay, and C4b as well. Okay, so this is a process of opsonization, the process of enhancement of phagocytosis called opsonization, and opsonines C3b and C4b and C5 as well. Next one.
60 years old, non-smoker, present 3 months history of loss of weight, malaise, and breathlessness. On examination, left supraclavian node enlargement, chest radiograph revealed multiple bilateral opacity. What abnormality would biopsy a left supraclavicular lymph node most probably show? Multiple abnormal mitotic figures.
This means what?
Neoplastic cells.
Very nice. Multiple abnormal mitotic figures. This is of neoplastic features. Next one. This is easy question, but I will let you know why this question is not that easy.
Okay, 78 years old woman with emphysema receiving 28% oxygen by mask has the following blood gas result. Okay, we have acidosis, PO2 low, PCO2 high with compensatory metabolic alkalosis. So we have partially compensated respiratory acidosis.
Okay, so you have here emphysema and receiving oxygen, whatever the percentage. So you have low pH, this is acidosis. PA2 less than 8, this is respiratory failure. And it's hypercarbic, as you see, PaCO2 is high. So this is called respiratory failure type 2 and respiratory acidosis. If you will look at the bicarb, this is alkalosis. So this is a form of partially compensated respiratory acidosis. Because who will explain this picture for us? Here, sorry. Yeah, this picture of low pH, some acids, PaCO2, because, and this is below 8, so this is respiratory failure. The PaCO2 high will explain this, and this rise in alkali trying to compensate. So it is partially compensated because pH is still very low. But if pH is normal, and these values are struggling together, this will be fully or completely compensated. So this is a partially compensated respiratory acidosis. Next one. Impalpable testis in the left scrotum. What will describe ectopic testis?
Superficial root of Venus.
This is not asking about the most common position. Do you know what is the difference between undescended testis? True and false?
I don't know.
So you have to understand that the ectopic testis is a form of rare congenital anomaly that differs from undescended testis, which is called cryptorchidism. In the ectopic testis, the congenital abnormally located testis. Ectopic means away from the normal side of descent. So what is the value, how the inguinal ring forms? If you will see, this is one inguinal ligament and this is one inguinal ligament. And here deep inguinal ring and here is a superficial inguinal ring. Okay? So how this ring will be formed? Because the testis will come from here by the gubernaculum, will be down through the inguinal canal by the spermatic cord until reaching here. So this is the normal location of any undescended testis. But ectopic testis means that it is away from the normal pathway for the testis. So the normal pathway for the spermatic cord is the normal pathway for the testis. But apart from this, what are sites of ectopic testis? It will be away from these normal positions. Do you understand me?
Yes.
So if it's true, then you can find it in abdomen, undescended in the abdomen, undescended in the inguinal canal, or undescended in the inguinal ring. But if I asked you about something like in the root of penis or any part away from the normal descent, this will be ectopic testis, pre-penile, superficial, ectopic, transverse, scrotal, femoral, perineal one. Okay, so the root of the penis here is a different position, but any site here, it will be a normal position of a normally, not normally, but will be abdominal, inguinal, or suprascrotal. And by the way, the most common is superficial inguinal ring, and then inguinal, then suprascrotal, and then intra-abdominal. This is called true undescended testis. But this site is ectopic, away from the normal pathway of descent. Okay, next one.
60 years old man found to have 2 centimeter diameter mass in the upper lobe of his left lung. He excised, found that the region includes connective tissue, mature cartilage. This is hamartoma.
Hamartoma are non-malignant, just disorganized tissues. Do you know a type of polyps, a hamartomatous polyps? A syndrome with hamartomatous polyps?
Yeah, that's Jaeger syndrome.
Best-Jaeger syndrome with mouth brown pigmentations. Next one.
23 years old, a man present with 3 months following extraction of carious teeth with a plaque-like infiltration over the upper jaw with sinus formation. Yellow granules are present. This is actinomycetes.
Actinomyces israeli, yellow sulfur granules. Colonic ischemia, most additional source of blood supply to the territory of the inferior mesenteric artery. So complete occlusion of this is going to be middle colic. I will describe this in brief. So we have the superior mesenteric artery and inferior mesenteric artery. The superior mesenteric artery will give ileocolic that will continue as appendicular artery and will give jejunal and ileal branches and will give right colic, RC, and will give MC, middle colic. The middle colic actually will become like Nefertiti with two hands, right hand and left hand. The left hand will continue like this to form what's called the artery of Drummond with the left colic branch. Why? Because if you see here, the inferior mesenteric will give left colic and will give sigmoidal branches and will continue as superior rectal. Okay, so this is ascending, this is transverse, and this is descending colon. And this is sigmoid, and then the rectum. Okay, if I'm going to do cancer surgery, I will ligate to this side, I will ligate the inferior mesenteric artery. All branches. Okay, because the radicality is important in cancer surgery to ligate the artery from its origin. But in diverticular surgery, you will ligate distal branches in any non-malignant surgery. Okay, so who will continue supplying this region when you ligate this inferior mesenteric artery? what's called artery of Drummond that's formed by left hand of middle colic. So the answer here is middle colic. Okay, I hope don't understand this. Okay.
Okay. Intravenous drug abuser is having an echocardiogram for suspected endocarditis. Closure of the trachea.
Complete another thing, please. So if you will, sorry for interruption. If you will get this, the blood supply for the rectum will be dependent on the remaining branches of the artery of Drummond, marginal artery of Drummond. And also, don't forget that the rectum will be divided into lower one third, middle, and upper one third. The upper one third will take from superior
Artery of
rectum,
Drummond.
the continuity of inferior mesenteric. These sides will take from internal pudendal and the internal iliac. So if you have cancer here in the middle or lower one third, will take from internal iliac, directly or indirectly, internal iliac or pudendal artery. And pudendal will come also from internal iliac. Next one.
Intravenous drug abuser is having an electrocardiogram for suspected endocarditis. Closure of the tricuspid valve occur at the onset of which phase? Isovolumetric contraction. Okay. After being stabbed in the left groin, previously healthy 20-year-old man admitted to the emergency. He developed hemorrhagic shock during his resuscitation. 10 units of type O negative red cells and 6 liters of colloid were administered. 24 hours later, he noted to have severe dyspnea, for which he required intubation and ventilation on the intensive care unit. Which of the following would be the most likely cause for respiratory insufficiency? ARDS.
Very nice. Why?
Because he
Transfusion.
will have volume overload.
Yeah. Transfusion associated TRALI. Okay, transfusion associated lung injury is a form of ARDS. Okay. Next one.
Okay, 80-year-old man has history of hypertension controlled with thiazide diuretics, undergo transurethral resection of prostate cancer, androgen anesthesia, surgery is prolonged, recovery room he complained of nausea and headache, later become agitated and confused. This is TERP syndrome with hyponatremia.
This is dilutional hyponatremia because of the fluid of the irrigation will be absorbed and cause dilutional hyponatremia. Next one.
A 35-year-old man admitted to hospital with vomiting, nausea,
CBA,
and
cerebral
severe.
tumor, will compress both facial and vestibulocochlear.
Okay.
Okay, next one. There is erectile dysfunction because of
Pelvic splanchnic nerve.
and also incontinence as well, pelvic splanchnic nerves is 2 to 4. Ulnar deviation and unable to extend the fingers fully.
Rheumatoid arthritis.
Rheumatoid arthritis. If I asked you about the X-ray difference between of rheumatoid arthritis versus osteoarthritis. So you have to think like this. Osteoarthritis is non-systemic disease. You have only the following: joint space narrowing, osteophyte formation, subchondral sclerosis, and subchondral cyst formation as well. Okay?
Yes.
The treatment is non-steroidal and physiotherapy, brace, glucocorticoid injection, and maybe total knee arthroplasty. This is osteoarthritis. But rheumatoid arthritis, you will have joint space narrowing, arthritis, joint space narrowing, joint erosions, ankylosing, and finally, total joint destruction. It is a systemic disease. So you will find rheumatoid factor positive, ANB positive, CRB elevated, ESR elevated like this. Don't forget the difference between gout and pseudo-gout, okay? And please don't forget the difference between the hand manifestations of rheumatoid arthritis versus uh, the osteoarthritis. What do you know about Heberden nodules?
It is osteoarthritis found in distal interphalangeal joint.
So Heberden distal and
Proximal.
butchered proximal, Heberden uh, distal, Heberden DD distal. So this is called in osteoarthritis. Decurvantinosynovitis, it is a thickening of the abductor pollicis longus and extensor pollicis brevis due to myxoid degeneration. Female is more affected from age of 30s to 50s, and the etiology because of the repetitive and the prolonged abduction and extension of the thumb. Rheumatoid arthritis as well is an etiology, and positive Finkelstein test. The examiner will grasp the affected thumb and exert longitudinal traction towards the ulnar side. This will lead to severe pain. This is called positive Finkelstein test.
Yes.
What do you know about necrobiotic granuloma? This is a histopathology examination feature of rheumatoid arthritis. Okay. Next one.
At 22 years old, man arrived to emergency, sudden breathlessness, large pneumothorax, chest drain inserted in the left fifth intercostal space in the mid-axillary line, hemorrhage into the drainage bottle. What's the following structure is source? Intercostal artery.
Very nice. Intercostal artery is the main one. Next one.
65 years old woman collapsed, total hip replacement, pulmonary embolism suspected, ECG changes, T-wave inversion in V1 to V3.
Okay, so a large S wave in lead 1, a Q pathological Q wave in lead 3, and the inverted 2 wave in lead 3 especially indicates acute right ventricular strain, and this occurs in 10% of people with PE. And echocardiographic findings, if it will give you a right ventricular strain, this means massive pulmonary embolism. If no, this means that there is no massive pulmonary embolism. Sinus tachycardia is actually the most common ECG finding during PE. Okay. Next.
Okay.
A 40-year-old woman had the anterior lobe of the pituitary removed without post-operative supplements. So anterior lobe pituitary. So what is the pituitary will secrete? Pituitary secretions anterior and
TSH, ACTH, prolactin, growth hormone.
posterior will give ADH and oxytocin. This is called neural hypophysis. Will give oxytocin and ADH. Anterior will give many things. Will give growth hormone, adrenocorticotrophic hormone, TSH, and FSH, LH, prolactin.
Okay.
So TSH will be in absence. What next one? 83-year-old man in the stage renal failure, polycystic kidney disease. Good renal function is established, but for deteriorates serum creatinine rising. Which of the following likely responsible for this deterioration?
T-cell mediated rejection.
T-cell mediated rejection. So you have to understand the acute, actually accelerated, subacute, acute, chronic graft rejection causes. Next one.
In order to expose axillary artery, transverse skin incision typically made below the clavicle from point just lateral to sternal end of clavicle to the deltopectoral groove. Which of the following structure encountered thoracoacromial artery?
Oh, okay, thank you so much. Yeah. CSF circulation.
Yes, CT scan revealed dilatation of both lateral and third ventricle with fourth ventricle normal size, so it will be cerebral aqueduct of Sylvius.
Cerebral aqueduct of Sylvius. So you have to understand that the circulation of CSF is secreted by choroid plexus. Okay. Then
Yes.
go to lateral two ventricles, then interventricular Monroe foramen to third ventricle, then via cerebral aqueduct of Sylvius to the fourth ventricle, and then through foramen magendi and Luschka will go to subarachnoid space, and then will be absorbed through arachnoid villi to the dural venous sinuses. This is the CSF circulation. Next one. So if I asked you about obstruction to CSF flow from the lateral ventricles, from the third ventricle to the fourth ventricle, because as you see here, there is dilatation for the lateral ventricles and third ventricle. This means that the fourth ventricle, the outflow to the fourth ventricle is blocked, which is the aqueduct, cerebral aqueduct of Sylvius. Next one.
12 years old.
EE, eosinophils IgE.
Oh.
Vasovagal bradycardia or release of insulin. Can you tell us about this? Obesity,
gastric bypass surgery, post-operative. The patient will
dumping,
complain of dumping syndrome due to after meals there will be release of insulin and lead to hypoglycemia, which lead to dizziness, sweating, palpitation, and collapse. The typical features of hypoglycemia.
Early dumping and late dumping. Early dumping, why? Because
osmotic
undiluted hyperosmotic chyme into the small intestine caused by dysfunctional or by dysfunctioned or bypassed pyloric sphincter. This will lead to nausea, vomiting, diarrhea, and cramps, as well as vasomotor symptoms such as sweating, flushing, palpitations. This will be within 15 to 13 minutes after ingestion of a meal. This is called early dumping. But late dumping, because of postprandial hypoglycemia, will happen because of what? Dysfunction. Pyloric sphincter, chyme containing very high amount of glucose, suddenly will reach the small intestine, will lead to burst of glucose and then burst of insulin. This will lead to excessive insulin release and severe hypoglycemia. So here, release of insulin will lead to manifestations of hypoglycemia. This is called late dumping.
56.
The femoral artery. So the numbers is very nice. So you know the inguinal ligament, and you know the antepubic tubercle and symphysis pubis. Okay, so if this is the anterior superior iliac spine, this is the symphysis pubis, and this is the pubic tubercle. The inguinal ligament attached is from here. So inguinal ligament is related to the inguinal canal. So it is inguinal ligament, inguinal canal, So the deep inguinal ring is half an inch above the midpoint of inguinal ligament between the pubic tubercle and anterior superior iliac spine. Deep inguinal ring. But from pubis symphysis and the anterior superior spine, this is called mid-inguinal point. Here will be the femoral artery. Okay?
Yes.
So a point midway between anterior superior spine and the pubis symphysis is the femoral artery passage. Okay? Next one.
A 70 years old man complained persistent numbness, post-inguinal hernia repair. The numbness affect top of scrotum, root of penis, small area below the medial part of inguinal ligament, nerve likely to be damaged, ilioinguinal nerve.
Ilioinguinal is the most common nerve injured in this incident. Next, there is a girl diastolic murmur audible in the second intercostal space, second left.
Pulmonary.
So you have all patients take medicine. So this is second aortic, second left pulmonary, and the tricuspid will be fourth or fifth left side, and mitral will be
Fifth, mid-clavicular line.
just at the mid-clavicular line.
Yes.
No, you will have the mitral just medial to mid-clavicular line, left fifth, just medial to medial to mid-clavicular line. This is the mitral. And also it's left fifth. Tricuspid, left fourth or fifth. Parasternal border. Okay, this is left, so pulmonary. Okay. Swollen leg, maternal aunt, similar problems. This is antiphospholipid syndrome. Repeated pregnancies, repeated abortion with repeated VTE. What is the most common congenital coagulopathy is factor V or factor 5 Leiden. Fight and flight. If I am asking about the primary metabolic response, this is going to be glycolysis, okay? Because it is a response of stress, but not tachycardia. Tachycardia is not a metabolic. Okay, so this is underwent emergency.
So with sepsis, we have tachycardia, decreased systemic vascular resistance, increased cardiac output. So it will be C.
It will be C. Okay. So yeah, we will return back to this. So again, metabolism, primary, yes, through beta 2 will lead to glycolysis, okay? We said this, you answered it. And here finds that in undergo surveillance colonoscopy reveals a plaque-like lesion in the descending colon, reveals a pre-malignant change. What is the name of pre-malignant change in pancreas?
Dysplasia.
Not hyperplasia, dysplasia. Okay. Next one. Dysplasia. Okay.
Okay.
Bladder.
And which region of bladder do the ureter pierce the bladder wall or posterior surface?
At L5, the opposite to the ischial spine on a chest on an X-ray, you find that the posterior surface or base, the same thing. So posterior surface or base, the ureters will go there, okay, to the posterior surface or base of the bladder. Tracheal rings. So what intervening
Good.
mostly require transaction?
Thyroid isthmus.
Okay, so okay.
Okay, step injury to the left groin. The wound is cleaned and simple dressing applied. 6 months later, the patient returned with pulsatile swelling. This is false aneurysm of femoral artery.
Pseudo-aneurysm associated with any previous vascular access, IV drug user, and the previous injury. So it is pseudo-femoral aneurysm. Yes, next one.
72 years old man, body mass index 18.4, not eaten for 4 days. Following removal of adenocarcinoma of the descendant colon, urea 12, and create 346. Blood gas profile is ordered. So the patient will have metabolic acidosis due to starvation. So it will be A, low bicarb, metabolic acidosis.
Metabolic acidosis and compensated with some
Respiratory alkalosis.
respiratory alkalosis. So you will find PaCO2 is low by like this. So the patient is in metabolic acidosis and trying to wash out some CO2 as a compensation because respiratory is immediate effect. Okay, left side baseball, there is no broken bones, but the boy complains of numbers and numbness of the face below the eye.
Intraorbital nerve.
Okay, so there is multiple questions asked here regarding parotid surgery and submandibular gland surgery. Okay, so submandibular gland surgery can injure marginal mandibular branch. Official leads to drooling of saliva or a smiling difficulty. Okay, this is in
Yes.
submandibular gland surgery. Which nerve can affect it as well in submandibular gland surgery?
Lingual.
Lingual. What else?
Hypoglossal.
Hypoglossal. Well, you will find that sensation from the anterior two-thirds of the tongue will be lost. But the taste will be intact because this from chorda tympanofacial. This is lingual nerve. Hypoglossal, ipsilateral deviation of the tongue because it will give all extrinsic muscles of the tongue apart from palatoglossus from pharyngeal plexus and glossopharyngeal. But in parotid gland surgery, you will find that NNVA, this is a structure passing there. Like N is great auricular nerve, N another N are 5 branches of facial nerve. To the zoo by motorcycle, temporal, zygomatic, buccal, cervical, sorry, to zoo by
Mandibular.
marginal
Mandibular.
and cervical, cervical to platysma, marginal mandibular to rhizorius of smiling, and angry oris. Angry oris. Okay, so you will find that the facial trunk will come from a stylomastoid foramen here. Okay. So this is a stylomastoid foramen. So if I asked you about injury to a most common nerve is a great auricular nerve because it's most superficial. And then if I asked you who will not be affected, you will find that chorda tympanofacial for anterior two-thirds of the tongue taste sensation will be already left in the inguinal canal inside the petrous part of temporal bone. So this will not be affected. Chorda tympanofacial of anterior two-thirds of the tongue sensation. Okay, but motor branches will be affected in parotid gland surgery. Okay, very nice. Okay, we finished part 2 of Fawzia sheet. Thank you very much. We will continue until we finish 4 parts.